So, good evening, everybody. I welcome you all on behalf of Artemis Neurosciences Center uh, on the day of the World Multiple Sclerosis Day. So, this year, the theme of this Multiple Sclerosis Day is navigating multiple sclerosis together. Um, at our hospital, we tend to commemorate all these events very, very seriously, whether it is Parkinson's, epilepsy, stroke, or multiple sclerosis. So I think it's worthwhile understanding the importance of this disease to understand why this happens and what are the investigative opportunities, what are the treatment options, how do you treat these patients. So for this particular day, we have some of the best minds in the country who will present here during this discussion. So we have Dr. Netravati from NIMHANS, we have Dr. Tapas Banerjee from Kolkata. Then we have many other uh, specialists who would be telling us in detail about multiple sclerosis and its treatment. So I give the mic now to Dr. Manish Mahajan, who is the head of neuroimmunology at our center, a senior consultant, and he's focusing on multiple sclerosis.
Thank you, sir. So without further ado, I would like to start with the uh, proceedings of the day with all the blessings of the Almighty. Let's start and uh, to talk about multiple sclerosis, I would like to first invite Dr. Vivek Barun. He's a consultant neurologist with us to talk about the common symptoms of multiple sclerosis. Dr. Vivek, over to you, please.
Thank you, Manish, sir, for giving this opportunity. So today I will be talking about the multiple sclerosis symptoms. So my talk will be what is MS, what are some of the risk factors for MS, what I will see what are the common symptoms. So as we know, it is an immune mediated or chronic inflammatory demyelinating disease of the CNS affecting brain, spinal cord, and optic nerve. So in the picture, we can see this is the common nerve, and there is a layer around the nerve which is called myelin sheath. In the MS, myelin sheath is preferentially attacked, and because of which that the flow of information to and fro from the brain is affected, causing all the symptoms. So the common age group is from 20 to 40 years, and it is 2 to 3 times more commonly seen in the females as compared to male. What are some of the risk factors? So causes of MS are still unknown. It is believed to be due to interplay of genetic susceptibility and some of the environmental risk factors. So some of the environmental risk factors are Epstein-Barr virus infection in the adolescence and early childhood, tobacco exposure early, either through the active or passive smoking, obesity in childhood and early adolescence, lack of sun exposure, low vitamin D level, and genetic factors. And the inheritance of the MS is believed to be polygenic. Coming to the symptom of MS, so symptoms are variable and unpredictable, and no two people will have exactly the same symptoms, and it can change or fluctuate over the time. And one person might experience only one or two of the typical symptoms, and some may have many symptoms at the same time. So coming to the first symptom, vision problem. Vision problem is often the first sign and symptom of the MS with which the patient present to us. It usually occur in one eye, and it may cause pain in the eye with history of painful eye movement. Patient may have blurred vision also or dim vision with loss of color vision in that eye. Sometimes it can occur in both eyes, one followed by the others, and vision may be completely lost in the affected eye, or the patient may see a blurred or dim spot may occur in the center of the visual field with the peripheral vision remains unaffected. Second most common symptom is sensory symptoms. Sensory symptoms could be either in the form of tingling, or the patient may describe like feeling of ant or insect crawling over the extremities, or it can be in the form of numbness. These sensory symptoms can occur over the face or in the hemi body distribution occurring on the half side of the body, or it can occur in the both lower limb also. MSH is also one of the common symptoms. It may be the first symptom or could be the sign of relapse also. It is believed that it occurs in 1 out of every 4 people living with MS, and it can feel different for each person. So how does it feel like? It feels like a squeezing sensation. Many patient will say like ऐसा लगता है जैसे कि कोई बेड बांध दिया हो चारों तरफ से, and it is very uncomfortable sensation. However, some patient may feel it around their hands or legs or feet, or some may feel it around the head also. Then after the sensory symptoms comes the weakness. Some of the patient may come with the weakness. Weakness could be either in the form of hemiparesis, in which the arm, leg, and the face of the one side of the body may be affected, or sometimes can be paraparesis also, in which the bilateral lower limbs, both lower limbs are affected, and it becomes weak with or without bladder wall involvement. Bladder dysfunction is again common, may be seen in up to 80% of the population affected with MS. Some of the common symptom could be patient has to get up more than once a night to urinate, or may have increased bladder frequency. Sometimes they have to rush to the washroom to avoid having incontinence, or sometimes they may have incontinence also. And some of the patient may complain that they have difficulty when they go to the washroom, they have difficulty in initiating the urine, false urinary hesitancy. Balance problem may also occur in which patient has imbalance while walking with swaying, with history of fear of falling. Sometimes patient may have fall because of imbalance also. Many patients will have problem with coordination, may appear clumsy, and they will have difficulty with doing the fine activities. Fatigue is also one of the most very common bothersome symptom affecting the people with MS, and it generally occurs on daily basis and may occur early in the morning even after a restful night's sleep, and it tends to worsen as the day progresses, and it tends to be aggravated by the heat and humidity. And usually the fatigue seen in the MS is more severe than the normal fatigue, and it requires the more recovery time. Sexual dysfunction may also occur in the patient affected with multiple sclerosis in the form of reduced libido or impotence in the male, or dyspareunia in the female, or vaginal dryness also. Many patients with MS may have anxiety, depression, cognitive difficulty in the form of episodic memory impairment. This is also common. So all these were the common symptoms which I have discussed. But many patients, they see only the problem with this walking and difficult. But where there are so many hidden things which a patient with multiple sclerosis may experience, like bladder and bowel issues, which I just discussed, depression, headache, insomnia, sensory symptoms like numbness. Very rarely may have seizures also, may have tremors, vision issues, and weakness. Thank you.
Thank you, Dr. Vivek. That was a wonderful presentation. To follow is Dr. Archana Sharma, who will talk about the diagnosis of multiple sclerosis. Yeah, sir, we will have the question answer session during the panel discussion, sir. We'll definitely have that. So let us wait for the panel discussion and the audience questions, please. Thank you.
Good evening, everyone. So without taking much time, I'll be talking about how to diagnose this disease, which is known as multiple sclerosis. So this will be the agenda for today. I'll be briefly describing what is MS and how to conclude to a diagnosis of MS. We have all known by now that multiple sclerosis is an autoimmune disease of the central nervous system where your brain and your spinal cord is involved. So what happens is these are the nerve capping which basically gets damaged, and because of these damaged nerve cappings, there is decrease in the transmission of the nerve signals, which causes all the symptoms which Dr. Vivek has just described. So how to diagnose? The first and the foremost very important thing to remember is that there is no definitive diagnostic test for this disease which is known as multiple sclerosis. ऐसा कोई भी टेस्ट नहीं होता कि डॉक्टर साहब ये वाला टेस्ट करा लो और इससे पता लग जाएगा कि ये मल्टीपल स्क्लेरोसिस ही है. What do we have to do? We have to take a detailed clinical history and examination, and to aid that there are certain tests which can be done. which is MRI, the lumbar puncture, which is the spinal test, and some evoked potentials, and some blood test as well. The very most important thing is that we have to rule out similar other presenting illnesses as well. So in a nutshell, we have to go through all these blood tests, MRIs, cognitive testing, detailed clinical examination, spinal tap, and evoke potentials to come to a diagnosis of this exclusion, which is multiple sclerosis. When we talk about neuroimaging, MRI is the best modality to diagnose the old as well as the actively damaged areas. CT scan is not a very good modality. Sometimes when the eyes are affected first, then MRI orbits can also be done. Secondly, the lumbar puncture test, which we all know, it is also commonly known as the spinal tap test, in which the CSF is analyzed. This CSF is nothing but the fluid surrounding our brain, which is draining it. And it gives clues towards this disease and simultaneously also rule out certain infections or certain mimics of this disease as well. There are certain evoked potentials from which our eye and our ear, they can be tested. Because of the damaged conduction system, these will be delayed or prolonged. So not one single attack cannot, we cannot come to a conclusion that this is multiple sclerosis. Sometimes multiple attacks are necessary to reach to the final diagnostic criteria. And multiple sclerosis, as I already told, that there are certain mimics like vitamin B12 deficiency, certain infections such as Lyme's disease, certain autoimmune diseases like CNS lupus. All these things can also mimic multiple sclerosis. So we have to rule out all of these other things as well. There are certain symptoms in which MS can flare up. And these are the very 4 common triggers for that. One is the stress, second is fatigue, third is heat, and fourth is any kind of infection. Thank you.
Thank you, Dr. Archana. That was really insightful. अब हम आगे चलते हैं. हमें पता चल गया कि मल्टीपल स्क्लेरोसिस के सिम्टम्स क्या होते हैं. हमें पता चल गया कि क्या क्या कुछ मिनिमम टेस्ट चाहिए जिसके बाद हम मल्टीपल स्क्लेरोसिस को डायग्नोसिस को कंफर्म कर सकते हैं. अब करना क्या है, क्या हम कर सकते हैं मल्टीपल स्क्लेरोसिस के पेशेंट्स के लिए, उनको हम कैसे आगे डिजीज़ को बढ़ने से रोक सकते हैं. तो इसके बारे में बात करेंगे डॉक्टर मोहित आनंद. ही इज़ अ कंसल्टेंट विद अस इन द डिपार्टमेंट ऑफ न्यूरोलॉजी एट आर्टेमिस. ओवर टू यू डॉक्टर मोहित.
Okay, so talking about prevention of disability and principles of choosing the therapy for multiple sclerosis. So first of all, let's see how this disease progresses. If we don't do anything, if we don't treat the patient, we don't give anything. So ultimately the patient gathers disability, and over time this disability gets on getting accumulated, causing significant difficulty in performing daily living activities. But if we treat the patient at a later stage, they will accumulate less disability. And if we treat the patient early, so we limit the accumulation of this disability in the patient. So जितना जल्दी treat करेंगे उतना accumulation of disability नहीं हो पाएगा. तो अब करे कैसे? इसके 2 मेन पैरामीटर्स हैं. एक होता है acute relapse, which is the acute relapse of the patient, which is acute occurrence of symptoms like loss of vision or incontinence or inability to walk or any sensory complaints. So this is the acute relapse. We have to treat the acute relapse first of all and make sure that around 100% of the symptoms get recovered. तो जितना अग्रेसिवली ट्रीट करेंगे एक्यूट रिलैप्स को उतना अच्छा रिकवरी होगा, उतना एक्यूमुलेशन ऑफ डिसेबिलिटी नहीं होगा. So what are the available modalities for treatment of acute relapse? We can give methylprednisolone, which is steroids. If the relapse is very severe, if the symptoms are very disabling, then we can go for higher therapies like plasma exchange, जिसमें खून की सफाई जैसे बोलते हैं कि 5 cycles blood को साफ किया जाता है so that the acute symptoms disappear. अब सेकेंड अप्रोच क्या है? सेकेंड अप्रोच है कि वी डोंट लेट द सिम्टम्स टू हैपन, वी डोंट लेट द रिलैप्स टू हैपन. इसको करने के लिए जो हमारे पास मेन थेरेपीज हैं, दोज आर कॉल्ड डिजीज मॉडिफाइंग थेरेपीज, DMTs, जो आपसे हर बार डिस्कस होती हैं. तो इनका मेन मोटिव क्या है? मेन मोटिव हमारा डीएमटी देने का है, नो एविडेंस ऑफ डिजीज एक्टिविटी को अचीव करना, कि मतलब योर डिजीज इज नॉट प्रोग्रेसिंग एट ऑल। इसके कुछ क्राइटेरिया हैं, इसमें डाइवर्ज करने के लिए देयर इज नो नीड टू डाइवर्ज इन दीज क्राइटेरिया, बट बेसिकली वी डोंट वांट एनी रिलैप्सेस टू अकर, we don't want the disability to progress, we don't want any new lesions in the MRI, and the annual brain volume loss should not be that significant. So what are the modalities for achieving NEDA? Over a long period of time from 1993 going on to 2020, so many drugs have come up for the treatment of MS to decrease the relapse, to decrease the progression of the disease and to prevent relapses. So यही discussion होता है बार बार patient के साथ, which is the best therapy, which is the best therapy. So to decide that, we have to follow a flow diagram. We first assess what is the stage of the patient, how severe is the disease, how often the relapses are occurring, how aggressive is the disease. So if the patient is having a very aggressive disease, then we can start with more aggressive therapy, the higher level therapies. If the patient has an average disease, not a very aggressive one, then we can start with milder therapies in the form of oral tablets. But it is important, it is always important to make the switch at the right time. If your disease is getting aggressive, it is important to switch. कभी भी ये नहीं सोचना है कि एक ही डिजीज मॉडिफाइंग थेरेपी बेस्ट है, ऐसा नहीं है। डिजीज के स्टेज के अकॉर्डिंग हमेशा चेंज होता है ट्रीटमेंट। इफ योर MS is turning into an aggressive one, it is important to switch. So how would we know that the multiple sclerosis is still progressing or getting converted into an aggressive one? We can follow a simple flow chart. If the relapses are occurring, even if after starting off disease modifying therapy, the patient is still having a relapse within the 1 year, then it is a highly aggressive MS. If the number of lesions in the MRI are progressing, then it is a highly aggressive MS. If the EDSS, which is a scale to measure the disability of the patient, if that is progressing over a period of 6 months or 12 months, then it is highly progressive MS. So we have to make this switch. So when do we decide to make a switch? If all the lights in the previous chart were green, then there is no need to make a switch. The MS is controlled. We can continue with the same disease modifying therapy. If there are some yellow signals, some of the things are happening, the disability is progressing a little, maybe a lesion has occurred, then we can still wait and watch for 3 months to see the progression of the disease. But if more than one domain is red, there is highly progression, there is a lot of new lesions are happening, the disability is progressing, then we have to make a switch. And the gamut of disease modifying therapy is ever evolving. We have highly active therapies to deal against with highly active MS. We have milder therapies in the form of oral medications to deal with milder MS. The gamut of these medications will still be evolving. It is always important to choose the right kind of medication at the right time. Thank you.
थैंक यू डॉक्टर मोहित। सो अब सवाल आता है कि ये फिर मल्टीपल स्क्लेरोसिस डे क्यों? हमारे पास डायग्नोसिस के टूल्स हैं, हमारे पास ट्रीटमेंट के मोडालिटीज़ हैं, तो हमें वर्ल्ड मल्टीपल स्क्लेरोसिस डे क्यों चाहिए? क्यों हर साल 30 मई को मल्टीपल स्क्लेरोसिस इंटरनेशनल फेडरेशन ने एक दिन बनाया कि उसको चूज़ किया कि वर्ल्ड वाइड डिफरेंट ऑर्गेनाइजेशंस अपने अपनी कैपेसिटी में दोबारा से ये हर साल ये सेलिब्रेट करें, कमेमोरेट करें? क्यों? वो इसलिए कि अगर आप अपनी एक्सटेंडेड फैमिली या अपनी कहीं पे भी फैमिली में बात करें, तो वो मुझे नहीं लगता कि पहली बार में मल्टीपल स्क्लेरोसिस वर्ड सही तरीके से बोल भी पाएंगे। सो ये चीज़ मैंने सबसे पहले अपनी न्यूरोलॉजी ट्रेनिंग में देखी कि सब लोग ये पूछते थे मल्टीपल क्या? तो वो जो मल्टीपल स्क्लेरोसिस, क्योंकि एक वर्ड इसमें इतना इनहेरेंट पैथोलॉजी का है कि वो लोग नहीं बोल पाते उसको। तो बीमारी के जो हमने आज अभी मेरे सभी कलीग्स ने डॉक्टर सुमित से स्टार्ट करके, जहां डॉक्टर अर्चना, डॉक्टर विवेक और डॉक्टर मोहित ने जो अभी आपको नॉलेज शेयर की आपसे, वो नॉलेज तो बहुत दूर की बात है, वो मल्टीपल स्क्लेरोसिस का नाम भी नहीं ले पाते। तो ये जो नॉलेज है वो पब्लिक तक पहुंच सके। जब ये नॉलेज आ जाए तो अपने आसपास जो लोग मल्टीपल स्क्लेरोसिस से अफेक्टेड हैं, पीपल विद MS, उनकी जो डॉक्टर विवेक ने एक बहुत इंपॉर्टेंट बात की, इनविजिबल सिम्टम्स, तो उनके बारे में उनको नॉलेज हो, क्योंकि जो चीज़ बाहर से दिख रही है वो केवल वही चीज़ नहीं है। तो इसको समझते हुए, जैसे ही मेरी 10 साल पहले ट्रेनिंग खत्म हुई और जो मैंने अपने टीचर से सीखा, उसको मैंने 2015 में एक इनिशिएशन लिया कि वर्ल्ड एमएस डे को कमेमोरेट करना चाहिए। उस टाइम पे मैं चंडीगढ़ में था। मैंने 2015 में उसको वहाँ पे एक सेंट्रल स्टेट लाइब्रेरी के अंदर यंग लोगों के साथ कमेमोरेट किया। तब येलो ऑरेंज कलर के जो है बैलून्स को रिलीज करना एक बहुत कॉमन वो होता था। फिर मल्टीपल स्क्लेरोसिस इंटरनेशनल फेडरेशन ने हर साल कुछ थीम देना शुरू किया और मैं भी गुड़गांव शिफ्ट हो गया। एंड तब मैंने गाइडेंस और लीडरशिप डॉक्टर सुमित के साथ ज्वाइन किया और उन्होंने मुझे परमिट किया कि इस सोच को, इसको आगे और लेके जाओ। तो 2018 से लेकर अभी तक हम रेगुलरली हर साल, इवन ड्यूरिंग कोविड टाइम्स, और कई आप में से लोग हैं जो हमारे साथ तब से जुड़े हुए हैं, तो वो देख रहे हैं कि हम इसको कंसिस्टेंटली आगे, एज पर द इंटरनेशनल मल्टीपल स्क्लेरोसिस डे का जो वर्ल्ड एमएस डे का थीम होता है, जो कि इनविजिबल एमएस रहा, फिर एमएस कनेक्शंस रहा, और इस साल नेविगेटिंग एमएस टुगेदर। तो ये जो टुगेदरनेस है उसको हमने कभी नहीं छोड़ा। तो ना केवल पब्लिक, ना केवल मेडिकल फ्रेटर्निटी, आज हमारे बीच में एपीआई के प्रेसिडेंट भी हैं गुड़गांव चैप्टर के, तो डॉक्टर रविंदर, एंड ये सब लोग इस चीज के साथ हमारे साथ हमेशा जुड़े रहे हैं कि हर साल मई के महीने में हम इवन फिजिशियंस के साथ भी ये जो नॉलेज है, व्हाट इज द लेटेस्ट अपडेट इन द फील्ड ऑफ मल्टीपल स्क्लेरोसिस, वी यूज टू शेयर विद देम। और सबसे इंपॉर्टेंट चीज है कि हम इवन ऑफ्थल्मोलॉजिस्ट के साथ भी इसको डिस्कस करते हैं, क्योंकि बहुत कॉमनली जो विजुअल सिम्टम बात करी, विजुअल लॉस है, वो एक सिम्टम होता है। तो ये एक जर्नी है जो कि हम इतने सालों से साथ चल रहे हैं और आगे एक्सपेक्ट करते हैं कि आप लोगों की इतनी सपोर्ट और इतनी जो आप लोग एंथुजियाज्म हमारे में रिफ्लेक्ट कर सकें ये। तो आई थिंक और टाइम ना वेस्ट करते हुए हम कुछ सवाल ले सकते हैं। जैसे अभी हमारे ऑडियंस में से कुछ सवाल थे, तो वो एंड में है जो
Hello, hello, hello. He mentioned one of the criteria is genetic. Genetic criteria also is related to MS. Now, genetically, if somebody is there in the family, then MS is more prone to MS. But on research, it is seen that I have also done the research on net and all. Only hardly 2% of people population can have MS genetically. Only 2%. That 2% is very, very small. Genetically, I think should not be one of the reasons. It can be any other, it could be stress, it could be wrong medication, it could be any other XYZ thing. Genetically should not be, genetically, it could be a fall. Genetically, I think should not be stressed too much.
Genetic predisposition is not there, sir. It is very rare. It is hardly there. It is hardly there. Genetic predisposition wasn't talked about. Mainly, East, some races, Scandinavian countries, winter weather, they predispose. Okay.
No, that is racial. That is genetically, if I have got MS, my son or daughter is supposed to get MS, or chances of her getting MS are very high. That should not be there because hardly 2% of that.
That is true. It is rare.
It's
The
very
chance
rare.
is there, but it is very less.
Very less. That what should be stressed on because you see if
sir,
young
alone genetics is not responsible. Other factors like environmental factors, दे आर वेरी इंपॉर्टेंट। बहुत सारी स्टडीज में ये प्रूव हो चुका है कि माइग्रेशन स्टडीज में कि प्यूबर्टी से पहले अगर आप हाई रिस्क एरिया में जहाँ पे एमएस की प्रेवलेंस जैसे कि हमारे पास स्कैंडिनेवियन कंट्रीज के अंदर ज्यादा देखने को मिलती है, तो वहां पे अगर लोग शिफ्ट हो जाते हैं तो उसका उनका रिस्क जो है वो ज्यादा है एज कम्पेयर टू जो लोग नहीं माइग्रेट हुए हैं। तो ऐसा नहीं हम कह सकते कि जेनेटिक्स जीरो है, मगर उसका रोल है और डेफिनेटली एनवायरमेंटल फैक्टर्स बहुत इंपॉर्टेंट है।
Why I am stressing on this is that you see people in 30s and 40s are getting MS, and if we stress that genetics is playing a very important part, then chances of their conceiving, having a baby, and further progression of the population unnaturally stops. Unnaturally you are creating a कीड़ा in your head.
मैं आपका पॉइंट समझ गया हूँ और इसी के लिए हमने कभी पैनल डिस्कशन में बहुत इंपॉर्टेंट क्वेश्चन भी है, हम इस पे आएंगे और हमारे पास बहुत एक्सपर्ट पैनलिस्ट हैं आज इन चीज़ों के बारे में बात करने के लिए। तो अभी जस्ट कुछ ही देर में हम ये इसी टॉपिक पे दोबारा डिस्कशन करेंगे। आपका आई थिंक उसमें सवाल का जो है वो जवाब मिल जाएगा।
थैंक यू, थैंक यू।
डॉक्टर महाजन, ये ऑटो इम्यून डिजीज है और आप न्यूरो इम्यूनोलॉजी के एक्सपर्ट हैं। पूरे प्रेजेंटेशन में एक चीज़ जो मुझे लग रहा है कि मिसिंग है, जो ब्रेन के वेन हैं और स्पाइनल कोड हैं, मतलब जो एमएस का मेन रीजन है कि उसके ऊपर जो एक लेयर होता है माइलिन, जो आप प्रोटीन कह सकते हैं, तो उस माइलिन के ब्रेक होने के कारण से इलेक्ट्रिकल ट्रांसमिशन का गैप आ जाता है और जो मैसेज है आगे बढ़ नहीं पाता। तो एज ए इम्यूनोलॉजी एक्सपर्ट, क्यों ना उस माइलिन हार्मोन की भरपाई कर दी जाए और एमएस के ट्रीटमेंट।
सर बहुत अच्छा है, पर ये पहली बात तो माइलिन एक हार्मोन नहीं है, ये
प्रोटीन
रिसर्च
एंड फैट है।
बिल्कुल
प्रोटीन
सर,
एंड फैट है।
वो बहुत एक प्रोटीन्स और मल्टीपल टाइप्स ऑफ कंपाउंड्स का एक मिश्रण होता है। और जो अभी रिसर्च चल रही है वो एक्चुअली इसी पे चल रही है कि जो माइलिन को हम किसी तरीके से वापस ला सके, तो इसको हम रीमाइलिनेशन कहते हैं। नेचुरली कुदरती तौर पे भी जब डीमाइलिनेशन होता है तो रीमाइलिनेशन कुदरती तौर पे भी कुछ हद तक होता है, बट वो इनकम्प्लीट रह जाता है जिसके करके कुछ ना कुछ सिम्टम्स रह जाते हैं। तो ये सभी चीज़ों पे हम डेफिनेटली अभी अभी बात करेंगे और आई थिंक हमारे साथ हमारे पैनलिस्ट जुड़ चुके हैं और वी वुड लाइक कि इसके ऊपर और जो है आपका बहुत वैलिड पॉइंट है और यही आज की डेट में हॉट टॉपिक है रिसर्च का। रीमाइलिनेशन एक बहुत इंपॉर्टेंट और आई थिंक एक मीनिंगफुल रिसर्च है जो कि हमें डेफिनेटली वी आर लुकिंग फॉरवर्ड टू। ओके, थैंक यू। I would like to just confirm the backend team whether the panelists have joined.
Yes, sir.
Okay, so I would like to start the panel discussion and welcome. We have a very eminent set of panelists today. Can we have the panelists pinned on the screen, please? Backend team. Welcome, Dr. T.K. Banerjee, sir. He's a senior neurologist and director of neurology at National Neurology Institute at Kolkata. We have Dr. Netravati M joining in from National Institute of Mental Health and Allied Sciences, NIMHANS, from Bangalore. We have Dr. Satish. He's an eminent neurologist from Apollo Chennai. And we have Dr. Sumit, none other than Dr. Sumit Singh. And we have Dr. Kamakshi. She's a neuroimmunologist from Max Vaishali. So there are very pertinent questions. When we started this today's campaign and we decided about this World MS Day commemoration, we wanted to focus on few questions which are the most pertinent. अभी हमने देखा ये सभी क्वेरीज आप लोगों के दिमाग में उत्पन्न हो रही थी एंड इसीलिए हमने सोचा कि ना क्यों हम रिस्ट्रिक्ट करें आपकी इंफॉर्मेशन आपकी नॉलेज को सिर्फ 5 लोगों तक. हमने कुछ इंफॉर्मेशन शेयर की आपसे बट डेफिनेटली उसके ऊपर और डिटेल्ड एक इंफॉर्मेशन के लिए हम आगे बढ़ेंगे. एंड सो पहला जो सवाल है, फर्स्ट क्वेश्चन गोज टू डॉक्टर तपस सर, टू यू, दैट what is multiple sclerosis and what are the common symptoms and how common is actually multiple sclerosis in India? We have already had a presentation about what are the common symptoms of multiple sclerosis, but people want to understand what is multiple sclerosis and how common it is in India.
Good evening, friends. It's a very important day, the World MS Day. And thanks, Dr. Mahajan, to bringing us together with the patients to talk about this particular disease. This is a very important disease which affects people in the very young, productive years of life. Multiple sclerosis is actually inflammatory demyelination of central nervous system. And central nervous system, we mean by brain, spinal cord, and also an extension of brain. There's the nerves to the eyes, the optic nerves. Now, the reason why it happens, it's autoimmune disease, whether there is a genetic factor involved or there is a contribution of genetic and environmental factors, these are involved, and how they interact. We are not into this very comprehensive part of the real origin of multiple sclerosis as yet, but we know it's an autoimmune disease, and this is a disease which has a myriad of manifestations. The clinical manifestations, the patient first may develop acute onset blurred vision in one eye or even in both the eyes. They may present with the acute onset paralysis of the legs, or what we call paraplegia, or one limb gets paralyzed all on a sudden, or they may have acute unsteadiness of gait. So these are the sort of presentations the multiple sclerosis have. They might have some subtle symptoms to start with, like pins and needles in the hands, or feeling a little bit weak when they go out, get exposed to the sun. That sort of symptoms may happen, very transitory, but the main clinical event is what I have described already. These events, the characteristically, they resolve over a period of time, only to come back in another form sometime later, maybe after a year or a couple of years. And this is what we call, there is a relapse and there is a remission, and then there is a relapse again. So relapsing, remitting type of multiple sclerosis, that is how the disease is commonly present. There are some cases where they start getting progressive right from the beginning, but relapsing and remitting multiple sclerosis also, if it gets not treated for many years, they can go into a progressive stage. That means they don't have those typical relapses and remission. The remission may be partial as the days goes by, and then they progress over time slowly. And so if that phase occurs, then the patients gradually can become wheelchair bound or bed bound.
And how common it is in India, sir?
Yes, that's right. Because earlier on, we didn't think that multiple sclerosis existed in India. We thought that was a case in the Western industrialized countries, the Anglo-Saxon race and the Nordic race are the people who has multiple sclerosis. And the prevalence in their country is around 300 per 100,000. Whereas in India, I think that prevalence could be between 10 to 20 per 100,000, as we are sort of seeing more and more of these patients nowadays.
Thank you, sir. I would like to ask to Dr. Sumit, and we would like to know about that how common is the misdiagnosis of multiple sclerosis? Because we have already discussed about the diagnosis, but we would like to highlight that how common and how it actually can ill affect the treatment of people with multiple sclerosis or with other demyelination.
Yeah, thank you, Manish. Am I audible?
Yes, sir. Very well.
Yeah, so thank you for organizing this event, and thank you, Dr. Banerjee from Kolkata, who has made my task easier. So, multiple sclerosis can mimic several disorders. So, it can mimic a stroke, it can mimic several other types of disorders. So, if we miss the diagnosis and we don't treat multiple sclerosis in time, as Dr. Banerjee has rightly pointed out, then the deficit which is created by one attack of multiple sclerosis tends to add up with the next attack. And over a period of time, multiple such attacks will make a patient almost bedbound or wheelchair bound. And the type of multiple sclerosis, as already told, which is a relapsing remitting, which is the commonest one, can eventually become a progressive disease over a period of time and can be very incapacitating for the patient. So, of course, for the diagnosis, we have already seen that apart from the clinical details, radiological tests, some invasive cerebrospinal fluid tests, certain electrophysiological tests are helpful, which help us in making a diagnosis. But missing the diagnosis is even more dangerous. So, one has to look for other disorders which mimic multiple sclerosis and rule them out. That would be required by doing some blood tests, some radiological investigations, and some specialized tests, which are more important for the neurologists to understand rather than the general public.
Thank you, sir. Over to Dr. Netravati. She has a vast experience being the head of the neuroimmunology at NIMHANS. And ma'am, I just want to understand, first of all, welcome on board and thank you for joining. The basic thing, which is the most difficult thing to do, is disclosing the diagnosis of multiple sclerosis to a person who was first diagnosed with multiple sclerosis. So how do you do it? And I think, how do people take it? I think the current theme, that is my MS diagnosis, is actually something that's important aspect to it, that how do people receive that diagnosis? So in your experience, how do you disclose and discuss the multiple sclerosis at the time of disclosing the diagnosis?
Good evening, everyone. Thanks, Mahajan, for giving me this opportunity. It's really nice to address, especially when MS Day is there. This is a very relevant and very difficult question, what you have asked me. And I find it one of the most difficult thing to tell. First, especially when people have already been diagnosed with multiple sclerosis, and there is that small hope they come to us thinking that I may tell a different diagnosis. But so what I try to do is, when we are discussing with the patient, I basically try to tell them at what do they have and what is the possibility. But in the same breath, I also tell them that this is not something which is as bad as what they have seen in the internet or heard from somebody. A few years back, if we ourselves look, the options of treatment were very minimal, and what we could offer to the patients or people with MS was very less. But now the science research has grown to such an extent that we have many medications available and we can tailor make it according to what the symptoms or what their MRI is showing. So that our goal is to see that they live as normal a life as possible. I stress upon this and I tell them that not taking a treatment is not an option at all, but they have to take the correct treatment so that they live a better life. I also give them an example that if they take the treatment, they can be as normal as what they are at that point of time, but only with two conditions. That is, they follow what the doctors say, they go regularly. It is not that you take the treatment, stop them, and again become little bad and then go to the doctor. So it is building a trust with the people and then starting the treatment and continuing to do it for a longer period of time.
Very well
Thank
said, ma'am. And I think that's really insightful. Over to you, Dr. Satish. Dr. Satish, to mention over here, he's a very active member of Indian Academy Runners Group, and we have a lot of neurologist colleagues who are very pro fitness, and I think he's gonna stress, and I would like to know from him that what is the role of nutrition, because we have discussed few of the risk factors. Dr. Banerjee sir also mentioned about the genetics, the environmental risk factors. But from you, from the treatment perspective especially, I would like to understand that what is the role of nutrition overall in the management of multiple sclerosis?
Yeah. Hi, Dr. Manish. Thanks for being here. It's pleasure and privilege. So, as we discussed, we all know that it's a neuroinflammatory autoimmune disorder, and we all know the risk factors starting from the age and the gender and climate, viral risk factors, some dietary risk factors, some environmental risk factors like smoking, pollution, and other things. So these are all common, but we don't have one-to-one direct correlate apart from the Epstein-Barr virus, which has been viral trigger-related conditions. Talking to the dietary, as we know that MS is a disorder where it has a relapsing remitting, a progressive condition. So our aim is to keep our patients who've been suffering with persons with multiple sclerosis to be healthy and have a good quality of life. Most importantly, we have to reduce the relapse rate and have the disease progression to be limited so that they have a good quality of life. So there are so many diets available in the market, like so many Mediterranean, McDougall, and diets, but I'm not very catchy of all those names. So let us go to the basics. So the basic diets includes what the brain needs, the human healthy body needs is carbohydrates, proteins, fats, vitamins and minerals, and micronutrients. Okay. So talking about each one of them, we all should know that in multiple sclerosis, the diet should be like the carbohydrate should be a complex one, not a refined sugar like a added sugar, preservative sugar, and all those things. So try to take off whole grains, try to take off whole leafy vegetables, fruits in types of carbohydrates, then going for the other form of refined sugars and other things. Coming to the protein, it is advisable both the multiple sclerosis has a direct link from the gut-brain axis. So it will be better that you take a lot of lean proteins like plant-based proteins. Avoid unnecessary processed stored red meat. Lean meat like fish, which has good trans fatty acids, are good. So protein should be in the form of plant-based. When you talk about fats, always try to take unsaturated fats than saturated and trans fat, because the inflammation is more high in a ready-made processed oils, whatever available in the market. So try to take off better nuts, better oils in comparison to the processed oils and whatever you use for cooking. Coming to the micronutrients and the vitamins, we all knew that B12, vitamin D is very much helpful for MS disease progression, not only in restoring the inflammation and autoimmune cascade, also it is useful to maintain the very healthy weight, avoiding obesity. Your bones and muscles should be strong so that you can maintain a good balance, and you will feel fit even if you have a disease relapse, whether it affects the brain or the spinal cord. So to maintain the healthy body weight and fitness, you need good amount of vitamins and nutrients. So keep in mind. So what you should avoid, you can also substitute some essential fatty acids and antioxidants, just like vitamin E, all those over-the-counter molecules available. So you can include a lot of vegetables and fruits, a lot of whole grains, lean protein, unsaturated fats, and a lot of water. Avoid saturated fats, avoid trans fats, avoid refined sugars, alcohol, and try to cut down your products which is more processed. So maintain a healthy body weight so that even if the disease worsens with BDSS scoring, you will be able to keep yourself ample. So that's why the message from the dietary perspectives. Thank you.
I think maintaining the ideal body weight is the main target, because obesity not only has been shown to be pro-inflammatory, and the control of body weight, maintaining an ideal body weight definitely helps in controlling the inflammation. Thank you, Dr. Satish, for that insightful and detailed explanation about the diet in MS. over to you, Dr. Kamakshi. Thanks for joining in. And I know that you are on vacation and you just consented to be part of this. Am I audible, Dr. Kamakshi?
Yeah, Dr. Manish, you are
Okay.
audible.
Yeah. So we had beautiful discussion about the management of multiple sclerosis using disease modifying agents and the various paradigms which we use, the pyramid up approach, pyramid down. How do we? But in your experience, can you just briefly mention what all modalities you have in hand now, and how do you choose those modalities to manage medically the multiple sclerosis? And if you can touch base upon, there was a very good question from the audience about the remyelination therapies. So if you can just touch about that also. Thank you.
Yeah. Am I audible?
Yes, please.
Yeah, thank you, Dr. Manish, for inviting us to this webinar. So I think Dr. Netra has already laid the foundation for this answer. MS is like an evolving science. Every 6 months or so, we see a new drug in the pipeline. The science is not like 10, 12 years ago when very limited handful options were available for MS treatment. So nowadays we have a plethora of medications which the patients can take and which the options of these can be offered to the patients. So it all depends what stage of the disease you are in. It all depends what your MRI shows, and it all depends what are your symptoms. So depending upon those clinico-radiological correlation, few therapies can be tailored according to your disease activity. So these therapies can be either oral medications or some injectable medications. The science behind this is very simple. See, MS is something which is autoimmune. So we have to target our immune system, we have to modulate it so that it stops attacking our own nerves. So depending upon this, how strong you inactivate or modulate your immune system, the therapies can be divided into two paths. Either it is a medium efficacy therapy or a higher efficacy therapy. So previously, this was a concept that we go up the pyramid. Let's see the MRI and we say, okay, the burden of the disease is moderate and you are not enough a candidate to offer significant immunomodulation. So we used to start with medium or lower efficacy drugs like interferons or glutamate. So now the concept is changed. It's like hit hard, hit early. And so hit first. That is, as soon as the patient with MS is diagnosed. So MS is a science, it is a disease which has a honeymoon period. The more stronger you attack in the honeymoon period of the disease, more it will be amenable to therapies. That is what is called the pyramid down, flipping the pyramid approach. That is, we attack the disease as hard as we can once the patient is diagnosed with the disease. And once the disease is fairly controlled after some time, we can always de-escalate because the window of opportunity to treat these patients is narrow. And we don't know, as Dr. Banerjee has already highlighted, that the relapsing form of the disease is the honeymoon period where the therapies are most effective in the patients. As soon as they switch on to the progressive form of the disease, we have limited therapy options and the success of the therapies is also limited. So that switch is so narrow and it is so unpredictable that we cannot even predict how a patient transforms into those forms and the therapy options become limited. So as soon as a patient is diagnosed, it is important that good efficacy therapies are offered at the start of at the diagnosis itself. Among the high efficacy therapies, we have few injectable options which are given monthly, that is the injection italizumab. There are some injections which are offered 6 monthly like rituximab, and of new in the market, that is ocrelizumab, which are very feasible for the patients to take. So these are name therapies are different. Drugs like alemtuzumab are available in India, and even the stem cell therapies are available in selected centers. However, it is not about talking the names of the therapies. It is important that the disease is diagnosed at the right time and the therapy started at the right time so that the narrow window of opportunity, we don't lose it and the patients don't become disabled. That is what we say, fight for myelin, because controlling the disease is always better.
Yeah, thank you. If you can just briefly mention about the remyelination therapies.
Yeah, so remyelination is one concept that the science and the research has always been evolving upon. There were some experiments before this the remyelination concept came in, and when the rats with some optic nerve disease were given some hyperbaric oxygen therapy. It was seen that the myelin repairs. But the concept behind all, see, demyelination, the inflammation part of the MS and the degenerative part of MS, we know by the evidence now that the degenerative part of MS also starts way before we expect. That is, inflammation and degeneration are not two mutually exclusive parts in MS, and degenerative part creeps very early in the disease process itself. That is why the concept of progress, this PIRA and all have come up. Remyelination is one thing that the science wants to target, and there are numerous therapies which are being targeted and in research pipeline to facilitate the treatment of MS. However, still the remyelination is a very remote approach. It is very disheartening to say that we are talking about remyelination, but even in our country, the diagnosis of MS is so delayed that the patients who should be offered therapies, they lack much in the time, and we are in a sorry state of affairs to see the patients who are disabled, young patients, they come wheelchair bound just because the therapies were not offered at the right point of time. So remyelination is a remote approach. It is a future approach, but in countries like India, we should diagnose the treatment. We should refer the patients early so that the treatment can be started on time and disability can be prevented.
Very aptly said. And I think programs like this and also the upcoming webinar from Indian Academy of Neurology, autoimmune subsections, these webinars like this go a long way in spreading the awareness about the disease and its early diagnosis and treatment. Thank you, Dr. Kamakshi, for a detailed overview of the medical management of multiple sclerosis. Over to you, sir, Dr. Banerjee, sir. Dr. Kamakshi talked about the highly effective therapies. At the same time, when we talk about highly effective therapies, the other aspect to these therapies is very stringent monitoring for few of the adverse effects. So in your clinical practice, how much do you, and any message from your side to the general public about the need and the importance of the monitoring while on being disease modifying therapy, especially the highly effective therapies?
Thank you. That's a very important question. That the reason why highly effective therapies were not introduced that very much in the beginning of the treatment of MS is because of the fact in some of these therapies used to have very sort of very complicated kind of problem associated with it, and you have to monitor very carefully to sort of prevent this sort of complication. For example, natalizumab is one of the very highly effective therapy for multiple sclerosis. But one of the main problem with natalizumab is that this is a drug which has a potential of causing progressive multifocal leukoencephalopathy, which is a very serious disease of the brain, and there is no cure for it. It is this disease occurs caused by this virus, which John Cunningham or JC virus disease. So whenever you introduce a patient with natalizumab, first of all, you have to do a titer from the blood. This is called JC virus titer to see whether serologically this is JC positive. Viral index is serology is positive, viral index positive. So if it is positive, and if it is highly positive, like beyond, they say 0.9, I think we should not start this sort of therapy, because they have a high likelihood of developing progressive multifocal leukoencephalopathy, or what you call PML, in future. Now, if you find somebody has JC virus titer negative, serology is negative, in those cases, we introduce this therapy, but we then do careful monitoring at 3 to 6 monthly interval to see whether this index is going up. And if the index rises, we should not allow it to go beyond 0.9. If it goes 0.9, we have to be very careful, and we may think of switching off to another therapy. If the value is more than 1.5, it is always advisable to stop this particular drug and go to other therapy. The other ways of monitoring, like, we're doing 6 monthly or even 3 monthly, more closely, MRI scan of the brain to see whether the imaging shows features of PML. So this is one thing which is very, very important to monitor. There is another very highly effective therapy called alemtuzumab, which again needs very close monitoring, because in those cases it's a complete immunosuppression. The patient has a lot of risk in developing various infections like herpes zoster infection, like Listeria meningitis. So you have to sort of carefully monitor these patients to see whether the patient can be protected from these sort of infections. One gets a prophylactic treatment with zoster, anti-herpes zoster therapy while on the treatment. And another thing is the autoimmune diseases, which is another thing we have to be very careful when you give this therapy. The autoimmune diseases can be thyroid, autoimmune thyroiditis, but the other organs can also be damaged, like kidney, like liver, or can have autoimmune encephalitis. So these sort of high efficacy therapies were not very much used because of these potential complications. Now we have other kind of high efficacy therapies called B-cell depleter therapy. And the reason why this particular high efficacy therapy has become very popular is because the complication rate and the complication intensity is much, much less than alemtuzumab or natalizumab. So we have one high efficacy therapy, which is very commonly used in our country, which is called rituximab, which is a very potent sort of B lymphocyte depleters. And even if you give this therapy, we should monitor them by carefully doing the full blood count, the complete blood count with the metabolic panels and the liver function test. And so this is required. People go to do sort of CD19, CD20 level, which is sort of the receptors on the beta B lymphocyte, to see what is the level of B lymphocyte in the blood. And sometimes you can defer if they see that there is no B lymphocyte in the circulation. But nowadays, this is not very much in practice. What they do sometimes is that at 6-monthly interval to see the immunoglobulin assays.
Right.
So I mean, it is very uncommon, but immunoglobulin level can be low if we keep on giving beta depleter therapy over a long period of time. So that is what is assessed, because if that happens, there is a risk of some infections, particularly upper respiratory infection or urinary tract infection.
Very rightly mentioned, sir. I deliberately actually asked this question because a lot of time we are not spreading the negativity about the disease modifying therapies. Only thing which we want to spread is that what we should know that what we are giving, but we should know what we should be looking for while you are being on these disease modifying therapies. Very rightly and very aptly described and mentioned, sir. Just in continuation with it, Dr. Kamakshi, I would like to understand, Dr. Banerjee, sir, in the last point he made, that we have to look for the infections while being on disease modifying therapies. So would you like to pinpoint any specific points about vaccination and watch for infections in people in multiple sclerosis per se, and while being on highly effective therapies? And as we are approaching the time schedule, we have to be brief. My humble request to all the panel. Yeah, over to you, Dr. Kamakshi.
Yeah. So regarding the thank you. So infections, I think sir has briefly touched on this. So as far as the vaccination concerned, so see, ideally before starting any DMT, not only just the monoclonal antibodies, ideally a patient of MS should be vaccinated when
Dr. Kamakshi, your network.
and deem the patient. So therapies. In
Dr. Kamakshi, you can
am I audible?
your video. Your network issue is there, so you can just continue with the audio. Yeah, I think that will work.
Now, am I audible?
Now you're audible.
Yeah. So I was telling every patient with MS who plans to take a DMT ideally should be vaccinated. So as far as the live attenuated vaccines is concerned, offered and completed at least 4 weeks before you start a DMT for a patient. However, if a patient has been offered any inactivated vaccine, those should defer DMT at least 2 weeks after the completed. So if a patient of MS who is a bad relapser have time to plan the vaccination before starting a the patients can be vaccinated after giving a particular time break of the DMT use and the vaccination schedule for the patient. Ideally, before starting a DMT for bodies such as varicella, whether the patient has been exposed to chickenpox or has immunity for the chickenpox or not. If the patient does have immunity, ideally we should vaccinate. However, this does not preclude starting of DMT because avoiding a relapse is always good for a patient. Therapies can be planned later on. Patients who the vaccinations which we usually offer are those of chickenpox, pneumococcal, and annual influenza vaccine, HPV vaccine. However, recent scenarios, the COVID vaccination had come up in a big way. So, the as far as the immunomodulative treatment is concerned, no doubt the infection rate is increased in patients who are on DMTs. Vaccinations can prevent those infections. However, starting a vaccination does not preclude the starting of DMT. We can start at DMT and plan vaccination later. The vaccinations should include chickenpox if the patient does not have immunity, pneumococcal and annual influenza vaccine. COVID, I think most of us are vaccinated against it already, and HPV vaccine.
Yeah. Thank you, Dr.
Over
Kamakshi.
to you, Dr. Manish.
Yeah. Thank you,
Yeah.
Dr. Kamakshi. That was really helpful. And over to you, Dr. Sumit. You can switch on the mic and
It's already on.
yeah, sir. So, sir, we know that few of the symptoms can be residual after an attack, and they can appear as the disease progress. So, can you just quickly give us an insight how we manage the various symptoms in the people with multiple sclerosis?
Yeah. So let's start from the top. There can be cognitive impairments which responds to cognitive behavioral therapy. Then patients can have neuropathic pain, which can be managed by giving certain specific medicines like pregabalin, gabapentin, duloxetine, and others. Patients can have spasticity, which can be managed by giving baclofen, tizanidine, or giving Botox. And sometimes patients who are in the secondary progressive stage, we can offer them treatments like baclofen pump. Then patients can have fatigue, which responds to amantadine and multivitamins. Patients can have difficulty in walking, which can be improved by giving dalframtidine, which is available in India as Dalstep. So these are the common symptoms which can be managed by giving specific medications.
Thank you, sir. Over to you, Dr. Netravati. Another, I know that I have put in very difficult questions for you, but that's your expertise. Dr. Netra, can we have your video on? Dr. Netravati? Yeah, ma'am. So, ma'am, I think this is one of the very important questions which I would like you to highlight. That can you just dwell on the reproductive health in people with multiple sclerosis?
Thank you, Manish. So most of the time there is a fear because they have multiple sclerosis, their fertility is affected, or because they're on medications, they will not be able to conceive, or even if it happens, there may be some problem with the pregnancy. So this is one of the myth which is there. So I just want to talk on few aspects. One is, even if you have multiple sclerosis and you have started on medication, remember that you are not having a fertility issues. It's not that your fertility is decreased because of having MS. Sometimes when you have a lot of weakness in your legs, because of that, it may impair in your sexual activity. But other than that, it does not affect your fertility. And definitely it does not affect in you becoming a mother or a father. Either of the gender, it is not going to affect. And then the other thing is, when you're planning for pregnancy, always discuss with your doctor that you're planning for pregnancy, because there are few medications which should not be given if you're planning for pregnancy. Otherwise, most of the medications can be given. And now we know how the medications are acting and how long we can withhold them. when the people are planning for pregnancy. So a proper communication with your doctor and trying to give a drug holiday during the pregnancy period can be done, but that is possible only if you have proper communicated before and taken the medications regularly before. So what do we do is sometimes, like for example, if you're on some oral medications, we give a drug out washout period and then ask them to plan for their pregnancy. So if their disability is good, that means they do not have much of disability and they're able to carry out their pregnancy. Later, when required, immediately after the delivery, we start the medications. But sometimes when the disability is high and they require medication, then we continue it depending on what stages. So sometimes like glatiramer can be continued, interferon, natalizumab can be continued. So we give those medications, and even monoclonals like CD19 therapies can be given except in few trimesters of pregnancy. So we see that and then we try to tailor it and give the medication so that the pregnancy can be carried forward. But the problem is post delivery, we need to have lot of complications are expected. So we need to again be in touch with our neurologist and manage that so that the medication can be started as early as possible. Thank you.
Thank you, ma'am. That was really insightful. And before I move to the last question for the panel discussion, and we just move to the audience questions, we have with us Mr. Chandan Khanna from HDUR. We are so in the last leap of the panel discussion, we will be launching a campaign, and in association with the HDUR virtual events, it's a fitness our fitness partner for this campaign, and he's the co-founder of this organization HDUR. Welcome, Mr. Khanna. The backend support team, please kindly add him to the panel, please. So welcome, Mr. Khanna. And being an active member and representation from our Indian Academy of Neurology Runners Group, I would extend the last question to Dr. Satish, that what is the role of exercise and how do you see it in the management of multiple sclerosis and in the paradigm of treatment of multiple sclerosis? Yeah, Dr. Satish, am I audible to you?
Am I audible now, Manish?
Yes, you are audible
Yeah.
now.
Yes, so the exercise is a vital part of health. So just like diet, sleep, and other things. So even in multiple sclerosis, our aim should be to keep ourselves, maintain the body weight, ideal body weight, so that we can be ambulant for our longer time. So we will divide this into those people who are completely fit, like they have a good lower body, good upper body function. So this is like a normal people where they can do the basic fitness. So like everybody do, walking, swimming, cycling, and running, they can do all the activities. Suppose if the patient is not fit enough, if they have some amount of weakness in the legs or in the hand functions for the dexterity, it is advisable still they do some basic exercise. So what is the main schema of motto of exercise in multiple sclerosis is only three. The first thing is it's an aerobic. Aerobic is the one where it pumps your heart rate. So that is important for maintaining the healthy cardiovascular system. So either if you are fit enough, you go for walking, running, swimming, cycling, and other things. If you aren't fit, still you can do a lot of aerobic exercise, like basic improve your heart rate by doing some form of yoga, other exercise. Even doing bedside exercise for the upper body, the trunk, and the lower body. So there are two things. People who are completely weak, they need a passive movement of exercise by a physiotherapist or a caregiver. That includes a basic stretching of all the limbs to improve the range of movement. Sometimes if the patient have some amount of stability in some amount of joint, they can use it for improving the heart rate by giving more and more pressure and other things. That can be also given for the trunk as well as for the lower limb. Suppose if the patient doesn't have, apart from the aerobic exercise, we also have to concentrate on resistance and the strengthening exercise, which includes improve the muscle mass and the bone mass, so that you need some amount of stability if you have lack of balance, posture, and other things. So standing exercise, simple sitting to stand exercise for the lower limbs. If the patient couldn't able to maintain the balance, so ask the patient to stand five times, 5 sets a day, and then stand on one leg, stand with one leg and just rising the leg on the front and the side improves the balance, improves the leg strengthening, even if they are having weak muscles. Similarly, the upper limb, they can do just lifting the arms, rotating the arms sideways, all those things. So these are all basic things which can be monitored by a caregiver or a physiotherapist, or even nowadays we have smartwatches to assess all these movements. So the third thing is to improve your flexibility. So that's why you need a lot of exercises to improve the flexibility, whether you do yoga, whether you do pilates, you do resistance band exercise to strengthen your joints, so that you will avoid your fatigue or avoid your contractures and the disability. So I think even if the patient is completely not able to move around, it is advisable to do some basic movements, wherever the muscles and strength possible. If not active movements are possible, always advise to do a passive stretching and passive movements by a caregiver or a physiotherapist. Yeah, thank you, Manish.
Thank you, Dr. Satish. I think that paves the way for our campaign. Actually, I know that multiple sclerosis is a difficult thing to manage. We have a lot of questions even on live. We are live on YouTube, Instagram, and Facebook. So we have few questions coming up from the public, and they have asked about lifestyle roles. So many of them have been already answered, that what to look for if one of the disease modifying therapies has not worked. And I would like to summarize that all the panelists have really mentioned that multiple sclerosis is a difficult thing to manage, especially when we miss the bus. Initial window of treatment is something जहाँ पे हमारे को जब सभी दवाइयाँ काम कर सकती हैं, बट वो अर्ली डायग्नोसिस में उसकी की है. और मैक्सिमम अब जो दवाइयाँ हमारे पास अवेलेबल हैं इसके ट्रीटमेंट के लिए, उनका पर्पस डिसेबिलिटी को प्रिवेंट करना ही है. सो हमें उस चीज़ की तरफ अब इसकी अवेयरनेस इसलिए ज़्यादा ज़रूरी है ताकि हम इसको अर्ली पिक कर सकें और सही मायने में पिक कर सकें. दैट मीन्स करेक्ट डायग्नोसिस, अर्ली डायग्नोसिस एंड ऑप्टिमल ट्रीटमेंट. वर्ड ऑप्टिमल बहुत ही इंपॉर्टेंट है. ऑप्टिमल मीन्स कि किसी की ज़रूरत अगर हाईली इफेक्टिव थेरेपीज की है तो हम मॉडरेट एफिकेशियस ट्रीटमेंट पे ना रुकें और उस विंडो में काम करें जहां पे वो एक्चुअली डिसेबिलिटी को होने से रोक सके. हर अटैक को रोक पाना हर इंडिविजुअल में अभी तक नेक्स्ट टू इम्पॉसिबल है, मगर जहां तक भी हम ये सक्सेसफुल हो सके हमें अचीव करना चाहिए. और ये सभी पैनलिस्ट शायद मुझसे एग्री करेंगे कि यही एक गोल है. इसके साथ साथ हमारे पैनलिस्ट ने एम्फेसाइज किया कि अगर सिम्टम है तो हमारे पास सिम्टोमेटिक ट्रीटमेंट भी है. सो जो 3 पिलर्स ट्रीटमेंट के हैं, एक एक्यूट अटैक के लिए रहता है, एक जो मेजर पिलर है वो है डिजीज मॉडिफाइंग थेरेपीज का, और उसके बाद सिम्टम मैनेजमेंट का. इसके अलावा न्यूट्रिशन और एक्सरसाइज दोनों हमें नहीं भूलने हैं. एक अच्छा लाइफस्टाइल, उसको हम और कभी भी एक उसका एम्फेसिस कभी भी कम नहीं होगा, वो हर एक इंडिविजुअल के लिए जरूरी है. और मैं इसी के लिए हमने जो अभी एक कैंपेन इस आज जो लॉन्च करने जा रहे हैं, और इसीलिए हमारे साथ आज मिस्टर खन्ना भी हैं यहाँ पे, जिनकी एसोसिएशन HDOR के साथ हमने हाथ मिलाकर ये इस कैंपेन को आगे लेके जा रहे हैं. ये कैंपेन हम लैंप लाइटिंग के साथ करेंगे, और मैं चाहूँगा कि हमारे यहाँ उपस्थित कुछ गेस्ट और डॉक्टर सुमित हमारी न्यूरोलॉजी टीम, डॉक्टर सचिन हमारे जो फिजियोथेरेपी लीड हैं, और HDOR के जो कुछ रिप्रेजेंटेटिव यहाँ पे हमारे साथ मिस सोनिया और मिस कीर्ति हैं, उनके साथ हम इस कैंपेन को लॉन्च करें. बैकएंड टीम प्लीज हम एक विजुअल क्या हम वो ले सकते हैं उस कैंपेन का स्क्रीन पे, और
Yes, sir.
प्लीज इसको फुल स्क्रीन कर दीजिए. और मैं चाहूंगा कि हम लैंप लाइटिंग को भी फोकस करें. सो ये कैंपेन है जो कि 2 भाग में डिवाइडेड है. पहला जो भाग है, दैट मीन्स पहली कैटेगरी जो है वो है जनरल पब्लिक और डॉक्टर्स के लिए, जहां पे वो लोग रजिस्टर करेंगे आज से शुरू होकर 15 जून तक. लिंक यहाँ पे है और हम इसको एक्टिवली प्रमोट कर रहे हैं, डिस्ट्रीब्यूट कर रहे हैं. हम चाहेंगे और एक कॉल करेंगे कि आप भी अपने फैमिली एंड फ्रेंड्स से बोलें कि इसमें बढ़ चढ़ के भाग लें. जो भी इंसान इसमें रजिस्टर करेगा उसको एक कस्टमाइज टी शर्ट HDOR द्वारा प्रदान की जाएगी। उसके लिए एक बहुत नॉमिनल से हमने एक सिर्फ लॉजिस्टिक चार्जेस रखे हैं, उसके अलावा कुछ भी ज़्यादा रजिस्ट्रेशन चार्जेस नहीं है, मगर वो एक सॉलिडारिटी, एक सपोर्ट दिखाने के लिए इस कैंपेन के लिए। और 21 जून से शुरू होकर 20 जुलाई तक 30 डेज का एक ये नेशनल फिटनेस एंड अवेयरनेस कैंपेन है जो HDOR के साथ हम आगे लेके जाना चाहते हैं। और इस कैंपेन के अंदर बेसिकली आपको 30 डेज के लिए अपने ही रूटीन में से एटलीस्ट 1 किलोमीटर चलना या भागना है। जितना ज्यादा करें वो आप पर है, और वो डेटा आप HDOR पे की ऐप पे अपलोड कीजिए। ये हमारे पीपल विद MS के फैमिली मेंबर्स भी कर सकते हैं, जनरल पब्लिक भी कर सकती है, और डॉक्टर्स भी कर सकते हैं। ये हुआ कैटेगरी 1। कैटेगरी 2, उसका रजिस्ट्रेशन लिंक आप अपने न्यूरोलॉजिस्ट से मिलिए, वो आपसे शेयर करेंगे इसके लिए। और वो जो लिंक है उसके द्वारा आपको रजिस्टर करने पे एक टी शर्ट और एक रेजिस्टेंस बैंड मिलेगा, जिससे जो डॉक्टर सतीश ने आपको एम्फेसाइज किया कि अपर लिम की भी कुछ एक्सरसाइजेस आप कर सकते हैं, तो वो एक्सरसाइजेस भी आप कर सकते हैं। जैसे ही आप रजिस्टर करेंगे आपके पास उन एक्सरसाइजेस की डिटेल्स आएंगी। डॉक्टर सचिन ने बहुत एक शॉर्ट वीडियो में वो बहुत अच्छे तरीके से डिस्क्राइब की हुई है। एक पैम्फलेट भी HDOR द्वारा आपको सप्लाई किया जाएगा जिसमें वो डिटेल्स होंगी। ये रजिस्ट्रेशन जो आपके डॉक्टर्स द्वारा, आपके न्यूरोलॉजिस्ट द्वारा आपको हैंड ओवर किया जाएगा, वो पीपल विद MS के लिए फ्री ऑफ कॉस्ट होगा, मगर उस लिंक को आप केवल अपने डॉक्टर से ले सकते हैं। सो ये एक हम्बल रिक्वेस्ट है कि इसके अंदर एक कॉल है पब्लिक को, एक कॉल है पीपल विद MS को नेशनली इस कैंपेन के साथ जुड़ने के लिए। क्या मैं आमंत्रित करना चाहूंगा डॉक्टर सुमित, अपनी टीम को और कुछ उपस्थित मेहमानों को कि वो हमारे लैंप लाइटिंग के लिए प्लीज स्टेज के करीब आए। स्निग्धा, आप प्लीज आ जाइए, आइए प्लीज। डॉक्टर ज्योत्सना प्लीज। डिटेल्स आपकी स्क्रीन पे हैं। और डॉक्टर इंदर हैं हमारे साथ, IMA के सेक्रेटरी गुड़गांव से। डॉक्टर इंदर प्लीज आप भी हमें ज्वाइन कीजिए यहाँ पे। सभी उपस्थित लोगों से रिक्वेस्ट है कि प्लीज़ अपनी सीट्स पे बैठ जाएं। मैं आमंत्रित करना चाहूँगा डॉक्टर सुमित को कि वो कंक्लूडिंग रिमार्क्स दें और फिर हम इस छोटी सी मीटिंग को
हेलो या मैं नीचे से बोल देता हूँ
सर आप यहाँ आ जाइए इसके क्या
इसके सामने
हाँ जी
ओके हेलो so I thank everybody who was present here, Dr. Netravati, Dr. Kamakshi, Dr. Satish. It was a great event in the time, and Dr. Tapas Banerjee. So it was a huge effort on part of Manish Mahajan, who has actually taken all the four corners of the country and brought them together on a single platform on this multiple sclerosis day. So we've learned a lot about MS in terms of its symptoms, diagnosis, management, how to live with it, the reproductive aspects of it, and everything. What is important is that this needs to be carried forward, and it has to be understood that multiple sclerosis is a disease which till yet was considered as rare in India. It is not so. It was considered that it is not treatable. It is not so. It was considered that it is definitely disabling and will take away your life quite soon. That is also not true. So people with MS can live a nearly normal life, and they have to understand the disease very well. Thank you very much.
Thank you, sir. I would like to have a few words from Mr. Khanna. HDR being our fitness partner for this campaign. Yeah.
Firstly, thank you, Dr. Manish, for letting HDR be a part of this wonderful venture in spreading awareness about MS. I think the biggest problem in a country like India is there are diseases, but there is very less awareness, and so there is a delay in taking the corrective actions. And I think this is the great step. We are very pleased and honored to be a part of it. HDR as a company also has this ethos to spread awareness about fitness and let people have or enjoy fitness, maintain a discipline, create that culture of fitness in family in the most affordable and a doable way. So हमारे लिए तो ये बहुत ही अच्छी बात है कि हम ऐसे इनिशिएटिव का पार्ट हो पा रहे हैं. Thank you again very much.
Thank you, Mr. Khanna. It's a pleasure to be associated with you for this campaign, and hope we have maximum registrations and to show the solidarity for this campaign. And in turn, this is going to be some trigger, and maybe it's just a starting point, I would say. And it's going to be a long journey. I've seen many things unfold in so many years in the last 1 decade since I have been commemorating, and over the horizon of the multiple sclerosis support for people with MS, I think nationally as well as internationally, a lot of is being done, but it's always falling short because the actual impetus has been just about medical. People think that doctors only talk about medical management, which is not true. We are also humans. We know that people need their disease to be addressed 360 degree. So we always try to treat our patients comprehensively. We want to treat and address their problems comprehensively. So these campaigns, I think, are gonna go a long way. And thank you once again. So I would request everyone to just stand in their on position for the national anthem, please. And then we can conclude. Backend team, can we have the national anthem, please?
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा चञ्चल जलधितरङ्गा तव शुभ नामे जागे तव शुभ आशिष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, everyone. Thanks for joining. Thank you, the backhand team and
Recording stopped. Recording in progress.
And thank you, people with MS. आप सबका बहुत तहे दिल से शुक्रिया. आप लोगों ने समय निकाला, आप लोगों ने इस मुहिम को हमारे साथ इस मशाल को आगे लेके जाने के लिए हमारे साथ हाथ मिलाया. धन्यवाद. And all thanks and all clappings to you. डॉक्टर इंदर, बहुत बहुत शुक्रिया. आपने अपनी बिजी प्रैक्टिस से टाइम निकाला और IMA को भी हमारे से ब्लेस किया हमारे इस ओकेजन को. हाँ जी, थैंक यू.